Folks, if you're listening to this recording, by the way, this is Eric Glazer. Thanks for listening to this recording. We forgot to press record. I forgot to press record. We're about 10 minutes in, and we're talking a little bit about outstanding questions from last week's episode around collaboration. I'm going to repeat the first question. Kessler, you were going to add something on there just for the folks listening on the recording. How do all the layers of healthcare work together to gather SDOH information without overwhelming patients by asking the same questions over and over?
Yeah, I was just going to expand on what Sean said to say it's not only about collecting the data in a standardized format, but then sharing it, right? So we as one organization are asking the questions. We're using the standardized data formats of Z codes and LOINC and SNOMEDs to document that. But if it doesn't go anywhere, if it's not being shared between payer and provider and downstream to the individual doc or social worker that's speaking to that member, then you are repeating that process all over again. That new person now doesn't have any history to look back on. So I think it's not only the standardized data, but how do you make sure that gets socialized in a way that everybody can see those questions, answers, and solutions.
Hey, Kesley, I would add to that, not even just downstream, but within the organization.
Yeah.
So whoever's talking, whether it's your customer service or your care managers, everybody's got to have that information.
Let's. I want to call on my friends in Denver. Shelley, like, are you guys doing anything to mitigate this? Because I know what I hear is everyone recognizes the problem. We all have thoughts on how it should be done. We haven't necessarily nailed down anyone that's doing a better job or not. I'm wondering what you guys are doing at Denver.
Yeah, so at Denver Health Medical Plan, this has been a bit of a challenge for us. We are kind of still in our infancy of trying to figure some of these things out. It's starting really with work inside our health plan on trying to get this data documented in our claims enrollment systems so we can pull from a central location and then kind of merge that information into gaps in care reporting and things of that nature. So we could work with doctors and vendors and things of that nature, trying to determine SDOH. Race, ethnicity has been our big focus, obviously, because we're still weak and behind the eight ball on that a little bit. And there's a lot of reporting elements that are coming to the forefront for us, and that's kind of where we've been working. And I haven't been on a lot of the panels with the hospital. The hospital system that owns us, they've been working very hard on a lot of those things too, in terms of just working with our community for those things as well.
Did you hear anything to add around what Centene's doing?
Actually, I'm one of the people who call members daily to do the SDOH. We provide social services. So we all try to work together with the nurses, the doctors, and we just try to give them the best service possible. Like you said, some of them do get aggravated when we ask them the same question all over again. So we try to go back on our notes and we just try to make like open-ended questions to make the member feel comfortable, and we have to follow up as many times as we need to. We'll just follow up.
Got it.
And we help them with social services as well. I'm sorry.
Okay, that's helpful. Andre, what about at UPMC health plan?
Yeah, we're still early stages, kind of on our end, trying to navigate kind of all the tracking, right? Because you can, as you mentioned, use the Z codes, and some use the Z codes, some use LOINCs. How do we connect the LOINCs to everything that we want to do, and making sure that it's all available to be seen. So there's all of those issues. And then I think one of the fundamental issues, right, that I think we're all kind of talking about is the how do we use the data? How do we use that information? I think the one thing that we're trying to do is equip, care managers, equip providers, equip nursing staff with some resources or things to do, right? Because you're more likely to actually ask the questions if you have something to offer. If somebody mentions, yes, I am dealing with domestic violence, then what, right? If you don't have anything to offer, don't have a connection point for them, then you may not be likely to actually ask the question in the first place. So just trying to offer just some useful ways to go about intervening at a even at a surface level before we even really hone in our skills on what specific things that we need to do from from a skill set base with our team, if it's not there yet. So that's kind of where we are right now.
I'm gonna shift gears, and what I'm gonna do next, folks, is I'm gonna ask one person a question, and I'm gonna pause and let people jump in, see how that works. I don't need to go around the room with each one, and then if anyone else has additional questions that are spawned, feel free to jump in. I don't want to maintain control, which I probably should have outlined at the beginning. But Yadira, I'm gonna bring you back in based upon your role. I'd love to get a sense on how you guys, especially since you're one of the people on the phone, how are you balancing just operations with all these topics tied to social drivers and social care? How does Centene balancing those? Because it takes so much more time on your care team's schedule, so it becomes almost a resource and mind blitz. And does that impact other parts of the business? Like, how are you guys managing that?
I work with a team of social workers who send resources to the members' home. So for instance, if the members needs help with transportation, we'll contact their PCP offices. If the member needs help with rent arrears, then we'll contact them with social services. So it is a balance. Pretty much when I call a member and they have those social services, then I'll put them on with the social worker, and then the social worker will take it from there.
Right, but let me ask you a different way. My guess is you're spending more time on the phone now.
Correct.
You're touching less members per day because you're focusing so much on mitigating social driver issues with your members. So you're connecting them with different people and navigating to where they need to go. That takes time on the phone. So maybe your call volume is down, or your touch volume. I don't know how you count it. I'm not a call center guy. So you can probably tell from my jargon here, but you're probably down by 25% or something. How are you guys managing that resource suck? Do you have a sense of how that's being worked on, or no?
To be honest, no, I really don't know.
Anyone else have an answer for that?
I guess I'll just jump in quickly to say the idea of having a link to a professional, if I understand what Yadira is saying, that they, there's a linkage directly to a professional social worker. I think that's really, a powerful thing to be able to do if you have that sort of dedicated resource that it sounds like you folks have, right? The ability to sort of say, hey, I'm going to bring this over and I'm going to have a dedicated team doing exclusively that. I think that's just ahead of the curve, right? In recognizing that this is its own skill set and sort of staffing to that, is just, it makes a lot of sense. And it's cool to hear that's kind of out there.
Yeah, I think that brings up the point, though, of also having being able to triage, right? Not everybody needs the social worker. Some people, I bet Yadira, not to put words in your mouth, but can you help some of those people yourself, and not everybody needs to go to the social worker?
Correct. So if they have one SDOH need, so what I would try to do is help them. I'll go to Google, I'll ask one of the social workers, and I provide them with that information instead of referring them to a social worker, because it takes them to them, open up a case, follow up, call PCPs, nurses, and stuff like that. So it is time consuming. We also receive a high volume of referrals from different parts of the organization.
Yeah. And that's what I think, the reporting is helpful. So when, we're doing outreach to our clients' members, right? Our team of advocates can help a lot of people, but there are certain programs that need more help. I know one of Andre's coworkers, John Lovelace, right, always wants, the question comes up all the time. What are you going to do with my homeless population? What are you going to do with those people? He always wants to, feet on the ground to really hold somebody's hands. And as a call center, whether it's, Yadira's team or our own, we can't help everybody, right? Some people need a higher skill level. And so the ability to document that with Z codes and be able to pull that out so somebody more skilled or feet on the ground can go help that person.
Yeah. I'm going to lob another question out there. I'm going to start with it because it's an Andre question, or at least Andre would be a great person to start with. And then I'm going to actually ask both Scott down in Arkansas, thanks for joining us, Scott, and our friends down in Denver to come in and address this question as well, because I think they're going to have different perspectives, where we have two sort of provider or integrated delivery systems here, and then Arkansas is a little bit more of a standalone. So I'd love to hear your perspectives on this. How can plans and hospitals and providers, and this comes from Trinity Health, how can you guys collaborate to meet respective social care compliance requirements better? So I know it's your sweet spot, Andre, so go ahead, you can start.
Yeah, so, wow. So, I mean, the collaboration's it's got to start really at kind of the basic level. From our standpoint, we're trying to understand, okay, what is the health, like from a health plan standpoint, we know what we're kind of beholden to, what we're tracking, what we're looking for. Where is that overlap? Where does that overlap exist from a patient, the patient-centered standpoint on the healthcare provider side? Ultimately, what are they trying to impact? What are they trying to get at? What are their regulatory bodies and whatnot requiring from them? And just kind of understanding that basic overlap. That's kind of where we've been at to start. The other thing we've been doing is just tracking what's some of the common issues and things that arise, right? From a health plan side, we may think it's, transportation and whatnot, but maybe the providers are saying it's more of, food insecurities and things with this, with a particular population. So just trying to address, in sharing the information as far as what we're seeing or what we're hearing from the members. So it's really that basic for us now. Like I said, we're in the early stages of trying to do this and do it, do it well. So we're really starting at the ground level right now.
Okay, you said something around figuring out with the hospital system, where is there overlap from a patient-centric view?
Mm-hmm.
By paraphrasing, but could you elaborate on what you mean by that and how you're looking to address it? Like, are you bringing in a consulting firm to do that? Do you have a separate, Tiger team doing that? Like, how is that being worked on?
Yeah, it's really a separate team. But I'll say it's like we have a so I work in the quality department on the health plan side, right? We have a quality department for our health services side, and just having regular meetings and conversations to understand what data and information they're seeing, what they're looking at. I'll draw the connection to member experience, right? There's, you have your caps on both sides, right? Your caps for your health plan, your caps for what on the health services side. So where are the overlaps that exist there, and how do we bridge those? How do we tie those connections to the important pieces that reside on the health services side that also reside on the health plan side, and how do we maximize our efforts to improve both? So we're doing the same, we're taking kind of that same approach that we've done on a member services and scaling that over to SDOH. But at the bare minimum, it's trying to capture that information, because I know a lot of us are still in the infancy stages of just getting that valuable data. So that's kind of where we're starting at.
Okay, so it sounds like what you're basically doing is you're having regular meetings with your counterparts on the service delivery side as a way to just keep the communication channels going with a formal process at a higher level on how to do this.
Mm-hmm. And ultimately, the goal is to hopefully match some of and develop new benefits and things that we have for our SNP programs or our CHC programs that we've identified are commonalities between the both of us. That's the ideal mark of what we're trying to do here.
What about down in Arkansas, Scott? And maybe just give us your name, title, and just so as an introduction. We all did that before you got on. Like, how are you doing that with your provider partners?
Yeah, so like I said, my name's Scott Love. I'm the Arkansas Blue Medicare Member Experience Manager. Will apologize. I'm pretty sick today, rocking a pretty decent fever, so I don't sound great, and that's why I don't have the camera going right now, to be honest. So we really leverage our value-based contracts with providers, and we do we do monthly and quarterly meetings with them around that. I like to go in and look at what their look at what their scores are going into the meetings. Then we have those just real conversations with providers around what their quality scores look like, how that's impacting members. And then really kind of have that fresh and live conversation going from there.
Okay, so monthly meetings as well. Are you able to do it? How are you able to do that? How do you pick which providers you're going to work with? Are you just choosing your largest networks, your largest health systems? I mean, you have a lot to deal with being the largest payer in your state.
Yeah, excuse me. Yeah, we typically do kind of stratify it that way. We have our larger ones that we'll have those meetings with. But we also have meetings, and our team, our outreach team is very thorough. We do have meetings with some smaller provider groups that may only have 12, maybe 15 members, and we still have the same conversations because those members matters too. So we'll have those with groups of all size. And then after that, our liaisons get out into the community. They go straight to those doctors' offices and work with them to impact those members with what they're needing at the time. And so so they may have more pharmacy-based questions. If that's the case, we'll bring our pharmacist in. They may have member engagement type stuff, and so they'll bring me in on that. So we really try to customize it based on what that provider group needs, and then what we can provide. So.
Denver, I'm gonna let you off the hook. I'm gonna do a follow-up question for the entire group. Is there anything beyond regular meetings with your provider partners that you are doing to effectively drive a strong collaboration between plan and provider around social care requirements?
Joe, do you have anything you want to add? Because I'm going to go for more from the data side of it. I don't want to speak over Joey if she's got something.
Thank you, Shelley. Yeah, I think right now we are just from our end, trying to reach out and collect data as much as possible at any touch point that we have with our members. So our outreach team or our pharmacy, things like that. When member calls in or we outreach to them for different matters to close gaps and things like that, I think the goal is try and set that up even with our care management team to collect that kind of data. But definitely, Shelley, if you could share what we're doing on the data side.
Yes. So some of the work I've had, and this is mostly because of pressures from NCQA for a lot more of detailed reporting for things on the SDOH and race ethnicity side of things. I've actually started a working relationship with the Denver Health EPIC team, the EPIC medical record system team, trying to find areas in the medical record data where we have commonalities for data points that we need and getting those out of that system and into our back end data table so we can pull from that. And that's been kind of a nice back end way into getting some of the information, or actually a lot of information that the hospital system collects on several of these areas.
Are you just, Shelley, is that really just identifying gaps and social barriers, or are those providers and documenting like that they've also helped the member to close those gaps?
Yep. So documentation for closure gaps, documentation of any needs that they have. So we as a health plan know that those needs from our side. So sometimes we don't always have that until I talk to a case manager or a social worker on our side. Just getting any data points, race, ethnicity, income level problems, ride problems, transportation, any of that kind of stuff, just trying to get that. So we have a main housing location of that data based off of what's been documented in the medical record itself.
So if the provider hasn't solved for it, though, if they didn't call an Uber for that member or patient, do you follow up and try to help the member to get transportation or whatever the barrier might be for before their next visit?
That's the intent. We haven't gotten that far yet because I just started this about a month ago or a month and a half ago, trying to work with our data epic team on this. And as things happen, right, sometimes other things take precedence over what we ask as a health plan. So we're a little slow on getting this ship sailing, but we're getting there.
Got it. That's great.
Anyone else want to chime in with any differences? That was great. Thank you for that, Shelley. I want to shift as if Kelly was seeing my kind of cheat sheet that I'm working off, but the next area where I want to sort of talk about is, and there's a someone from Humana that asked this, but it's very in line with Kelly's question that you see in the chat, is sort of what are some of the more effective ways to build relationships with members and communicate directly to build that trust and collect the right data and make sure that they're getting the right services they need. So I'm going to just, I guess I'll lob it over to you first, Kesley, but I'm going to then, after Kesley's done, I'm going to pause and see if anyone else wants to jump in and share their stories about how they're little things. It could be little nuances that you're doing to build a better relationship with your members and do the right thing for them.
Yeah, this kind of goes back to everything we've done for 20 years ago. When we started doing social care, it wasn't because anybody used the term social care or social determinants of health. We did it because it improved member engagement. It allowed us to start a conversation. We have a tagline, we lead with help, right? But it's really about just, how can I help you today? What are your needs? How can I help solve for those needs? And really, one of our key criteria when we hire in a call center is, are you a good listener? Are you empathetic? Can you show compassion? And while we do most of this all over the phone, right, those are important attributes that have to come out because that's how you build credibility and trust. And starting with easier things to solve by listening to what their needs are and then going deeper. Collecting the data, closing the loop. We work directly with CBOs. We have people that are responsible for building relationships at an organizational level as well as at a CBO level, so that we can get better reporting and data. But when you're talking about, I think the biggest social determinant of health out there is financial insecurity, right? And so helping people to become dual enrolled or lowering their prescription copays with LIS or getting enrolled in SNAP, those are all programs that are government sponsored programs that we get data directly back in the form of documentation from CMS or from SNAP and so forth that we can close the loop that way too. And I think those are some of the most meaningful programs out there. Money solves a lot of problems regardless of what the problem is.
Anyone else want to chime in? There has to be some innovations being done about how we communicate with members, whether it's a data-driven approach, whether it's just changing the words and the scripting.
To that point, Eric, the words and the scripting, several of the plans I'm working with are adding what we're calling a CAPS hug at the end of every call, regardless of the interaction. Is there anything else that you need today? Have I answered all of your questions? It really is standard customer service, but reaching in there and saying, are you getting the help you need? And making sure that you're communicating with those members really clearly. And then you end up with your downstream effects. If they're going, you know what, I couldn't get an appointment. Okay, well, not only is that a CAPS measure, but it also is closing your gaps and improving the health outcomes, which ends up hitting your bottom line.
I love that, a CAPS hug.
Yeah, I do too.
I'm going to steal that. I can almost see that as a title of an episode, Gene. Please make a note of that. Right. Sorry, Sheree. Maybe I'll give you credit. Maybe I will. Anything else? I mean, that's exactly what I'm looking for. Like, I'm a big believer in these small little things. If it can make a huge difference if they're scalable. A CAPS hug process to make sure you train your team on a CAPS hug. God, that's just
yeah, low hanging fruit.
Low hanging fruit, exactly.
Yeah, I
Eric?
think, multi-channel communication still plays a role, right? Can you simplify things by sending follow-up via text, right? And not having to wait for mail? Can you give somebody a link or a phone number being via text so that they can store that information and not have to grab a pen? All of those type of things, and using omni communication channels, I think improves the overall, how you reach your members, how you follow up with them. I mean, I bet everybody on this call rather have a text than find a pen in their purse, right? So
What about you, Jim? You were going to say something because you're right on the front lines. Talk to me about Caps Hug.
Now, I was gonna say that we have a program that's called GOMO, where we send text messages to our members. So just like Ms. Kesley said, they feel more comfortable and more at ease. Okay, maybe I don't want to talk right now. I will answer you whenever I'm available. I was also gonna say that I'm a Spanish-speaking person, so I feel like I have a better understanding with the Spanish-speaking community because they feel like, you know what, she understands the language. I can speak to her directly rather than having a translator where a lot of things gets misinterpreted. So I would say that language barrier sometimes could be an issue because, culture, diversity, they may feel uncomfortable, or certain religions or certain people may not feel as comfortable as coming to us and saying, I need help. I need psych help, or I need social needs. So yeah, just having that compassion, asking, is there anything else that I can do for you today? Feel free, and even if they don't need any help, I still give them the customer service number and let them know if there's anything in the future, please feel free to give us a call back because we are here to help you, and just making them feel at ease at all time, I would say.
The Centene put a lot of emphasis on matching language or ethnicity with members and the people on the other side. Is that something you guys spend a lot of time on, or is it more than just hiring a lot of folks who speak two languages and you're going to hit enough that way?
If you speak more than one language, I would say that is an advantage, but we have a translator that we call directly that has like 500 different languages. So let's say I get a Russian speaking member, I would say, give me a second, I'll call you right back. And then I'll have the translator. I will call the member with the translator, and then, we'll go from there.
If I could jump in, I mean, I think it's fantastic what you're doing. And I think the sort of cultural fit element makes so much sense. But the challenge is sort of like, how do you know in advance even if you could say I can get any person in the world on the phone, understanding who do I want to have on the phone, right? So using things like, hey, what's the language preference that's out there, as a starting point is really fantastic. But it also goes beyond language too, right? I mean, we do a lot of work with, for instance, the veteran community. So when we started out, we said, all right, we're going to hire a bunch of veterans to do that. That's great. But then also where we found more success was actually hiring spouses of active duty military members and finding that they can connect very well with the veteran community. In some cases, even better than veterans. Just it really works well to say, oh, my spouse is currently deployed. Let's talk about your veteran status. It's really great. So there's you can really do those cool things if you say, I'm calling into somebody that has this type of a cultural background, language preference, that sort of thing. The limitations of it, the challenge I think we all wrestle with is sort of like, how do I know that in advance so I know the ideal person that I want to be having this phone call?
Yeah. Oh, go ahead, Andre. Sorry.
No problem. I was gonna chime in and agree with some of what's been saying. I think right to Yadira's point of having the language goes a long way. It's all around hiring, just diverse groups, right? So one thing I know at UPMC we do is we'll try to have health fairs or employment fairs and whatnot in different communities and different areas where we know we have a lot of membership or have a growing membership, so we can hire from that same community that we're looking to impact. So same thing from the veteran community as well. Our veteran plan is made up and built by veterans, right? So they know what is needed for that particular population. So just trying to do that more and more. Another thing we've done on the Medicare side is we have what we call a Medicare Faith and Wellness program. that we started years ago, where we have a team that goes out and connects with faith-based organizations to promote healthcare, so that the health information isn't coming from us or coming from their doctor or coming from their nurses. It's coming from their, from their other parishioners. It's coming from their faith leaders, so that it's coming from a different lens, a different voice, and it can help promote, and then thus gaining that trust, building that trust, since we're the ones funding it and promoting it, so that then when they do contact us, they have there's more of a higher likelihood of them sharing additional additional information and things with us, behind their direct healthcare related needs, so that we can hopefully address some of their social needs and social things that they're dealing with. So it's a combination of a million things that have to be done in tandem in order to kind of get that all together.
Is there a dynamic, Scott, with rural and urban that you have to deal with, where you get someone who lives in Little Rock talking to someone out at a farm and there's not a connection? You got to match that way. I'm just curious if it's different for you guys in Arkansas, but at the same time.
Yeah, absolutely. I mean, having and Arkansas is a beautiful and very rural state. And we have small pockets of urban centers, but even then, we just don't have a strong public transportation. So there's even challenges in parts of Arkansas that would be considered more urban. There's still challenges because we don't have a strong public transportation system in some places, and then you get into rural areas, and that issue is just compounded. So, definitely challenges that we're working with day to day.
So it does sound, I mean, I'm gonna put a bow on this one, unless anyone wants to interrupt and jump in. It sounds like plans are investing a lot in diversity of their, I don't know, Yadira, if you want me to call it call center, but like the frontline folks. And Andre, you referenced this as well. And then the ability to enable those folks to be flexible, because you don't know, to Sean's point, who's coming in, and being able to enable them is important. And then to Kesley's point earlier, having the ability to communicate with folks and follow up, whether it be live on the phone, follow up with a text, or just sending a text, like it's called the GOMO program that I heard, are ways that are super effective right now. But I guess I'm not gonna put a bow on it. I'm gonna put one question out there. I'm guessing I'm gonna hear silence, but like, where does this go in the next 3 years? Where's the next innovation, even if it's small, around just communicating and making it easier to communicate with folks who are typically hard to reach in healthcare?
I can chime in and speak. So one thing, around kind of what you summarized there, one thing I know we're doing within UPMC is our preference center. So we're gathering all of that kind of demographic information, the preferences and things that our members have told us they want, as far as how they want to be communicated, languages and all those things, and try to put that in a easy to view space, so that when our call center reps are talking with those members, they can see all of that information, and hopefully 3 years down the line, right? And if we're talking the next 3 years, it'll kind of queue up to go to those individuals when they call in, right? We can have some of that. The other thing I think about too, and maybe this is a positive, maybe it's a negative, but I feel like more artificial intelligence is going to be introduced. So if you're talking about text messaging, you're talking about instant messaging, having more of a a conversational AI bot that can communicate easily to members, and it gives you more time, to have to intervene in only those that are the most complicated. And I can see that from talking about a call center, call it a kind of entry level health issues, to even more complicated health issues, right? So I just see AI becoming more involved, like I said, for better or for worse.
Yeah, I hope it makes like the triage at American Airlines and stuff better, so I don't have to yell at that computer anymore. Just give me an agent.
Yes, but then
Yeah.
AI is gonna take over. Let's say if AI can call 500 members per day, then what do they need me for now? So I'm scared.
I think what we really have to monitor, like what you're collecting there is great, Andre. But what we've done over the years is, did everybody pick text because it's the easiest to ignore? Or did they pick text because they really want to communicate? So looking at those preferences and then saying, did it actually work? When we use the text instead of a phone call, did the member follow up more? Or did we end up having to call them anyways?
I think also going earlier in the process at enrollment. The enrollment process, especially for Medicare, is pretty involved. But you have this application. A few years ago, they added the email address. Well, that's a great opportunity to say, how do you want to be communicated with? Do you want text? Do you want email? What number? Making sure that you're using all of those tools that are already at your fingertips to gather the information. And then once you get it, how are you capturing it? How are you sharing it within the organization? And that tends to be one of the bigger challenges today, is getting it into a system in a usable way.
Andre, last question here, because this is more selfish, but I'm curious your take on it. So I don't want to go on a soapbox or where I just think our lives are in our lifetime. I'm going to age everyone, just looking at everyone. We're sort of the same generation. Maybe Dira gets to be a little bit cooler on us, but I would say the single most, we've had a couple of major changes in our lives. When we were kids, I think the advent of cable was massive for all of us. Then we got this thing called the wireless phone. But I think the single biggest thing in change of lifestyle that's still impacting society greatly today is the smartphone. And what Apple did and now obviously the Androids are doing. I think that's all going to be dwarfed over the next 6 years with AI. No doubt it is. I think it's scary. I think I'm actually a little bit pessimistic about it because it's so powerful. But that aside, Andre, I still think for people who are 55 and above, when they see a chat icon or a bot of any kind on a website when they're trying to get help, they automatically go to, they're not going to get the right questions answered, and they are already discounting it as a way to interact. Like it's just, they're not interested in dealing with this guessing on what I may want through some computer program. Now they're not thinking regenerative AI is taking it to the next level. And so I'm curious what you're thinking at UPMHC on how to cross that chasm where you're going to have some really sophisticated technology that may be almost as effective as a human being, but we're not there yet. And there's already a stereotype to what bots provide as a customer service front door.
Yeah, I definitely don't think we're there yet. But I would argue, as, let's say 6 to 10 years, right, the Medicare population is going to be folks that have been used to texting and AI and search engines and all of that, right? So they're gonna know all these things that we know now. Like it took this long to develop into this point, right? Let's say, this was all introduced now in its kind of great format and we didn't have these growing pains that we're feeling now. I could see kind of that sentiment that, folks wouldn't trust it and wouldn't, embrace it just because they have that, expectation that it's not going to get them where they are. But I think over the years, we're going to trust it more and more. Like I said, for better or for worse, I think there's a lot of things that you're going to see benefit from a healthcare standpoint, right? Where I think we're seeing a lot of that now when it comes to like, radiology and things of that nature, when you're looking at machines that are, capturing, higher or more accurate rates of, detecting certain, anomalies and stuff, whether it's cancer related or what have you, or, bone breakages and things like that within x-rays, right? They can do it, like that in a second, and their specificity and rate and sensitivity rates are excellent, so I can see that happening more and more. And then I think that'll all also come down into conversations, right? We're seeing it more and more with obviously with ChatGPT and the what it can produce. Now the accuracy is the issue, right? But as far as it being conversational is almost, you wouldn't know it's not another person on the other end of it. Now you just got to make sure that those AI platforms are being pointed to accurate information, and that's kind of the easy part of it all, so to speak, right? We just make sure it gets pointed to academic journals and to NCQA documentation and all that kind of stuff. The conversation, I think they got it down pretty good right now.
I think it's easy enough to keep trying it, right? Like right now, I'm pretty sure that bot on, again, American Airlines, not to pick on them, right, isn't going to provide the help that I need. But it doesn't hurt to type in a short question to see if it gives me help. And so as long as I'm willing to kind of keep doing that every so often, one of these days it's going to be helpful.
And just, I mean, one thing I wanted to jump in on this with, because I do agree in terms of dissemination of information, I need to find out X, Y, or Z that we're going to see AI continue to progress on that front. But I kind of have had what Yadira said in her earlier bouncing around in my head, that there's interactions where we're looking to get information, and then there's interactions that just because of the, just to get philosophical, who we are as a species, we need a human connection that are going to be different, right? And that's the role that Yadira, I feel like your role is secure, because there's ways in which people are not just looking to get information, but they're looking to build a connection. And when you're looking to really say, hey, tell me about what's going on in your life, that's not a bot role. That's not a simple exchange of information. That requires that human connection to say what's going on, and I'm another human being on the other end here that cares about you and that wants to make your life better. So I think you're going to have to be thoughtful about, is this an interaction where I'm looking to exchange information purely, or is this interaction that really should be built around a true human connection?
Yeah.
Yeah.
People want to share their story, right? They want somebody that's going to be compassionate and empathetic to listen, not just type in, I need transportation.
Right. Yeah. I think I see it kind of as the first layer of the funnel. Like that's what kind of AI will be. And maybe it'll keep you there if that's all you need. But yeah, to your point, both Kesley and Sean, you'll have to have that graduation process, that scaffolding process to, okay, there's a human touch that needs to happen here. So
last question, because we're getting tight in time, and should have maybe asked this earlier. It was my favorite question that we had from our submitted questions. I'm going to start with our folks in Denver, since they've been a little bit quiet for a bit. So it's your cue to stretch out here. If you could only do two things to raise your star rating, what would you do, and where would you put those resources?
Hi, Shelley. I could go first real quick and then definitely chime in. I think for us right now, the most important thing is data collection. We can't understand what we would do or how to manage until we have the data to understand what it is that we have to work with, and then take the direction, depending on what the data is telling us. So I think for right now, for us, it's the data collection piece, trying to get all of that information in-house, and then to digest and understand that before we make plans and do outreach and things like that for our members.
So specific to like the HEDIS measure, the SNSE, right? There's requirements that you solve for those data challenges, that you solve for those SDOH challenges within a timely basis. So if you're only collecting, how do you operationalize the follow-up on those?
Yeah, and I think that I'll probably step in here. I think that's where our struggle has been, right? Getting leadership, getting the hospital online, getting all of that online, and operationalizing all of that information so that we're not duplicating things, and that we're efficiently getting things done as a system that's integrated with a health plan that's owned by the hospital system, right? I think it's kind of interesting, because I think of Kaiser a lot and how they do things, and their staff model. We're sort of a staff model too, but we are not near as advanced as they are in how they are able to do those things internally. And I think that's where our struggle is and where our money and efforts need to be put to try and get that in line.
Anyone else want to chime in on 2 things to do to increase stars?
I was gonna say that just really quickly, one of the things that my company right now that we are, I would say struggling with is our start rate, because a lot of people are not recertifying for Medicaid or for Medicare. Prior to the pandemic, they were automatically enrolled. So now it's more difficult to have each and every person enrolled. So that's one of our challenges right now, to get people to enroll with us to recertify.
Yeah.
I'd like to reemphasize what Shelley and Joey were saying. The information, pulling it all together and recognizing how interconnected all of the STAR metrics are. If you are gathering the right information, you're identifying the needs for the members, you're making it easy for them to get the access, you're going to close your HEDIS gaps. You're going to make them have a better experience because they feel heard. They're going to have better health outcomes in the end. So making sure that your STAR program is fully integrated across the organization and that everybody understands that they impact stars. I don't care if you're in claims, if you're in enrollment, if you're in customer service, if you're in medical management, you're all impacting that member's experience and the member's life that's going to feed into your STAR ratings.
Exactly. And I think I'm going to add in here too, that's been another struggle for us. And I'm not sure as an organization why we don't focus more on this, but our grievances that are coming in should be front and center way more than they are, because right there is a reportable complaint that you know is a pain point, right? And that has been a problem for us too.
I have the scars from A&G to go along with that. And if there is anything going wrong in your organization, or if any of your members have needs, you're going to hear about it in appeals and grievances first. So use that data, use that information, and then it will help you direct which way to go.
So one of the things I've been asked about, and I'm actually going to health, one of my main objectives of health is to vet this out, is if we should start an executive council or mastermind group with a focus on MA. And I don't know if that's even too broad, if it has to be more specific to that. And it would be something where we would get together synchronously through Zoom or live quarterly, and then asynchronously throughout the month with an objective and some deliverables that my organization would provide. I'm not looking for feedback on this. It's 11:59 here, but if you guys are interested in hearing more about that or providing me input on how that would be valuable to you, please reach out to me. You know where to find me. I thank you all for being part of this. This was super interesting and useful, and I hope we could do more of these. Sometimes it's a bit of a lift from my team, but we had an open week to do it, and we knew we had a hot topic, so I'm glad we were able to do it. Angie, I'm sorry you joined late. My guess is you're in the central time zone. I got your time zones a little bit mixed up, but we started.
I am so sorry. Yeah. I got pulled into another call and I thought it would be shorter. And then, those moments where you're like, don't want to be rude. And I was like, oh man.
I understand. Before we all go, I'm just gonna quickly stop the record button here. And so that our folks who want to listen to this have it.